to introduce our next speaker. Before I do, let me say something. The way I see this HIV/AIDS, I see it not just as a disease. It's not like any other disease. It's really a struggle for social justice and human rights. Because when I see across the world who is not on treatment, who hasn't tested, who is falling out of treatment, who is at risk of infection, it is people on the margins of society. People whose rights are denied, who don't enjoy equal rights as citizens, as other citizens. I was looking at the profile, or let me say the epidemic as it looks, say, in the richest country in the world, in America. I was seeing it on TV, and I saw that this disease is concentrated more than 75% amongst Black people and Hispanic people. Those happen to be the racial groups that are the poorest. It happens to be amongst gay men, mainly. It happens to be in the poorest areas. So it's a disease of those who are on the margins of society. And if we don't deal with those challenges of social justice, human rights, no amount of science will end the epidemic. So here in Africa, the face of this crisis is girls and women. Again, it is to do with denial of rights, discrimination, violence against girls. A long time, in another life, I was a member of parliament. Or I wanted to be a member of parliament. I was a young woman and I went to contest the election. Then the people in my constituency, they said, "Why are you, young woman, trying to take a seat away from a man? We already have a man who is a minister. Why are you trying to displace him, you young woman?" So I needed to justify to the people why a woman should also lead. So I decided to tell them a story at every rally. I would tell them, look, I met an uncle of mine when I was 20. I had never met him in my life. As I was trying to have a conversation, I said to the uncle, "Do you have a wife?" He said, "Yes." "Do you have children?" He said, he shook his head. He looked sad and he said, "I have one child and 3 miserable girls." That's how he described his family. 1 child and 3 miserable girls. Because a girl is not a child, traditionally in my own area. In many parts of Africa, a girl is not valued as a boy. A woman is not valued as a man. And so when this AIDS crisis was ravaging our continent, it was women again who rose first to organize themselves, to bury the dead, to look after the orphans, to care for the sick. It was women. So, but still today, women and girls are more vulnerable because they are not valued, because their rights are not respected. This is a question of women's rights. So it's my pleasure, and really a great pleasure, to introduce Rosemary Mburu. I hope I've said the name right. Rosemary Mburu. She's one of those African women who rose, who led when this crisis was raging on our continent, and who continue to rise and lead. She's currently the Executive Director of the Society for Women and AIDS in Africa, based in Senegal. Her organization works to address the higher vulnerability of women and girls and their families to the HIV epidemic. She has 20 years experience working on HIV/AIDS and sexual and reproductive health and rights. Ms. Mburu is also president of the civil society organizations platform working on health in her country, Senegal. Rohaya, it's my pleasure to give you the floor to share with us your thoughts on leadership.
Merci beaucoup, Madame Mburu, et merci pour cette belle présentation. J'ai l'insigne honneur et le plaisir d'introduire le troisième thème de la session de cette plénière et qui porte sur un grand défi que la plupart des pays ici présents rencontrent. Il s'agit principalement du financement de la santé. Nous constatons que les partenaires externes qui financent la plupart de nos programmes de santé se retirent progressivement. Et pour que nos pays puissent maintenir les acquis et espérer accéder à la couverture santé universelle, il est plus que nécessaire d'user de stratégies puis puiser sur nos ressources domestiques. C'est dans ce contexte que j'ai l'immense plaisir d'introduire celle qui va nous entretenir du Health Financing, Community and Private Sector Engagement for Increased Domestic Funding. Ce thème sera introduit par Madame Rosemary W Mburu. She has been a champion for healthy communities for over 15 years and currently serves as the Executive Director of Waki Health. Mburu is a civil society leader in Africa and have extensively worked on supporting civil society to engage with decision makers at community, national, regional, and global levels. She is a civil society organizer working on building and strengthening civil society networks and platforms on health-related advocacy and campaigning in Africa. Her contribution in building spaces that facilitate Africa's civil society's engagement and participation in global health include the Civil Society Platform on Health in Africa, CISFA, Global Fund Advocates Network, GFAN Africa Up, and Africa Free of New HIV Infection. In her day-to-day work, Mrs. Mburu works to create political will towards improved health outcome from all in Africa by engaging with governments, key multilateral and bilateral institutions such as World Health Organization, the Global Fund, the Stop TB Partnership, and the World Bank. Mburu has served on various global health institutions governing structure, including the Universal Health Coverage 2030 Steering Committee and United Committees Advisory Group. Ms. Mburu holds a Master's in Public Health from Ohio University, a Master's in Business Administration from Fosbury State University, Maryland, and a Bachelor of Education from Kenyatta University in Kenya. Please help me to receive Mrs. Mburu to have the floor.
Good morning. I have the pleasure of speaking from a community and civil society perspective. My topic, as well highlighted by my chair, Rokaya, is on health financing, particularly looking at how community and private sector engagement can support efforts to towards increased domestic resources. I want to first of all salute my fellow community and civil society advocates for all the work that we continue to do as a community, and to say that we are not yet done, it's not yet Uhuru. So in terms of this particular presentation, next slide please, I would like to first of all acknowledge what the African leadership has done. So looking at political leadership, the commitments and the frameworks, and then, as you know, our role as civil society is not only to speak about the progress that has been made, but it's also about calling out where states have also failed. We'll look at what is holding us back in terms of mobilizing new resources, but also in terms of utilizing the resources we already have in a way that is effective and efficient. And then just looking beyond financial barriers and recognizing that even if we had all the money we wanted for the response, without addressing social barriers, we would never make it. And then look at a call to action. Next slide. So I want to first acknowledge that in Africa, there has been political leadership in terms of commitments around investing in health. Some of the investments and commitments have also been very specific to AIDS, TB, and malaria. So, for example, a lot of us are very familiar with Abuja in 2001, the commitment around 15%. We are also familiar with the African Union Roadmap on Shared Responsibility and Global Solidarity for AIDS, TB, and Malaria of 2012. There was also a review of the Abuja, which gave birth to Abuja Plus 12, set of call to action in 2013. We also are aware of the periodic high-level meetings on HIV, which give us the political declarations on HIV. Most recently, we also have a commitment from African Union member states around the Africa Scorecard on domestic financing for health, which has specific indicators and commitments by member states. And also then, most recently, we have the Africa Leadership Meeting, the ALM, on investing in health. Next slide. So I wanted to highlight that there has been that commitment, there has been that leadership. And even though there has been certain progress because of that kind of commitment, we cannot say that we are close to the finish line. It is especially very important because 2020 is only a few months, actually less than a month away, 2020. And so ideally, 2020 should bring us to the home stretch to 2030. But the reality on the ground is that we are out of track, we are out of target, and not very sure that we actually are going to hit the target or the milestones by 2030 unless there is significant change in terms of investments, in terms of ensuring that we address the social barriers, etc., etc. So, in terms of progress, we want to acknowledge that health expenditure in Africa has increased significantly over the last couple of years. But domestic spending has stalled and external funding has flatlined. So what does that mean for us? If domestic spending has stalled and external funding has flatlined, what does that mean in terms of who is paying for healthcare in Africa? What does that mean in terms of who is investing in healthcare? So distinguished delegates, this means that you and I are utilizing a big proportion of our household budget to meet our healthcare needs. We are paying out of pocket. We are meeting these medical expenses, and that has consequences and implications. The other thing is that coverage of key health services has increased. We want to acknowledge that. We have talked about millions of people put on treatment. We have talked about many scientific breakthroughs. We have talked about the process and the progress we have made, even in terms of vaccine research. But a lot of gaps still remain. For example, we are saying that still 1.1 million people in Africa continue to get infected. So we have new infections every year, up to 1.1 million here in Africa. We also have about 9.4 million people who still need treatment, and so on and so forth. There are so many other gaps as well. When you look at the fact that we know the tools that work, we know the investments that work, but are we investing adequately in what we know works to ensure that we actually make progress towards the zero? We still do not invest in the demonstration or discovery of female-controlled HIV preventive options. We still do not have that. We still do not invest adequately in that. We know PrEP works, for example. Countries are not investing adequately for the scale-up of the same. Voluntary medical male circumcision, we know it works. We are not investing in all these things that science has given us. And not just that, biomedically, there are also other structural and behavioral things that we know if we address will actually take us closer, and we are not investing adequately in that. The other thing in terms of progress and challenge is very critical because millions of Africans continue to fall into poverty due to high out-of-pocket health payments. So this I mentioned in my first point to say that households are actually paying for healthcare with really high out-of-pocket expenditure in Africa. We still have a lot of countries in Africa that are doing more than 40% of total health expenditure is coming from out-of-pocket. And because of that, there are implications. For example, about 11 million Africans are falling into poverty every year because of these out-of-pocket payments. Now, in the context of universal health coverage, where we are saying universal means everybody, and we are talking about care and access, where everybody can access that without financial risks, then we realize that we have a long way to go if we are going to get to there. Next slide, please. So, what is holding us back? Why do we have brilliant commitments, frameworks, guidance, all these declarations and commitments at a regional level and also at a global level, and yet we don't see investments growing as fast as we would like to see? So a few points to that. There are many things we could bring here for discussion, but I selected 6 of those. One is that there's a lot of wastage. There is a lot of inefficiencies in terms of resources in the region. So about 20% to 40% of health resources are wasted. Then there's also the issue around areas where we could tap to build a bigger base of revenues in our countries, but we are not doing a good job in that. For example, we say that one of the ways that African governments can raise additional revenue at the country level is by streamlining how we collect taxes, how we allocate, and how we account for that. And therefore, there's a lot of work that needs to be done around progressive taxation. And that is an area where we are not doing well in a lot of our African countries. And yet it is an area that can actually help us to mobilize more resources. So we also have this issue in Africa where we have loads of illicit financial flows coming out of the continent and going outside into other continents. So that, coupled with international tax evasion, this is money, these are resources within our continent that we could use to harness our financial base. We are not doing a good job in that. The issue of access to medicines, the issue of stockouts, the issue of medicines being so pricey, is something that we see in our continent. And one of the challenges we can call out is the fact that we have big pharma that put profits before lives. Of course, they are in business and they have to make profits, I guess. But I think there are models that can be utilized, that we can tap into to make sure that the issue of access to medicines is solved once and for all, and to make sure that the drugs we use in our continent is actually not taking all the health spending and all the money and driving families into poverty. The issue of absorption capacity, we have bottlenecks in that, and those are areas where we need to address, where ministries have money, governments have money, but in terms of absorption, the bottlenecks have not been addressed adequately. The issue of debt in Africa, even without digging deep into that holds us back as a continent in terms of ensuring that we have resources to invest in social areas. So debt sustainability, competing in the same fiscal space with health, with education, is a big challenge for us in the continent. Next slide. And so these are some of the things that as civil society we engage on day in, day out, in a struggle to see how can this be resolved. But like I mentioned before, even if you resolved these issues and ignored to address certain barriers, money alone will not do it. Money alone will not take us to the finish line. So as civil society and communities, we also engage in challenging member states, in challenging governments to promote and protect human rights, as well as invest in gender equality. For example, it is due to gender inequalities that adolescent girls and women remain at high risk for all 3 diseases. It is due to discrimination and legal barriers that key populations continue to get infected at unacceptable levels. Most of these are failures of states. They are failures of governments, which have not created enabling spaces or enabling environments for these populations to live fulfilling lives. I must also mention the issue around authoritarian and regressive political forces in our region, in many countries in our region. And these are undermining the rule of law and respect for human rights. And unless we solve these social barriers, no amount of investment is actually going to make access universal. And no amount of investment is going to get us to the finish line. So we must work on the financial barriers, hand in hand with the social barriers, as I mentioned. Next slide. So very quickly about private sector, just saying that there is potential to tap into private sector as a strategic partner in this, in terms of mobilizing additional resources, in terms of having private sector invest not just money, but also expertise that can support governments to allow everyday dollar to reach further through efficiencies. Private sector can bring its technology, its innovation, and work hand in hand with the public sector to actually invest more in healthcare. Next slide, please. So this particular slide is about saying that none of this will happen without communities. And we applaud you, Winnie. It was the call on World AIDS Day around the central role that communities play. And this is what we are reiterating. 3 points here to say that community-led and community programs are severely under-resourced. So we are talking about the central role of communities, of civil society, as strategic partners in ensuring that we get to the finish line. But the important work that civil society and communities do also has to be resourced, also has to be enabled, also has to be facilitated. For example, communities do critical work around monitoring and accountability. In various countries, we have community-led monitoring at the country level in clinics, monitoring of budgets, monitoring spending, etc., etc. But most of the times, you find that community-led monitoring is added into budgets as an afterthought. And it will be very strategic and useful if community-led monitoring, accountability piece of work is actually routinely funded as opposed to having that funded as an afterthought. I think that would be a strategic way of bringing civil society and communities as partners in the process. And civil society and communities, we will continue to commit our hearts and our souls in the work we do in terms of bringing our value to the table, but also calling out governments that neglect their people, but also rooting for those governments that invest in people. So basically, our work in terms of accountability, while also ensuring that we ourselves are accountable to the people that we serve, to the people that we work with, and also on the responsibilities that we have. So the next slide, please. Next slide. So having said all that and looked at the fact that yes, indeed, we have commitments, we have leadership, we have frameworks, we have all these declarations and other instruments that guide member states on how we could invest, on how to work to make progress towards the finish line. But we have also looked at the different challenges that we struggle with, the different issues that we actually need to address. So we are moving from just saying we need more money for health, but also saying that we need more health for the money that we invest. So just looking at what are we investing on, but also calling for leadership that is courageous enough to deal with the different challenges that we mentioned. So this is a call to action. We are calling for a leadership that not only signs on declarations, a leadership that not only makes commitments, but a leadership that goes a notch higher to actualize these commitments and to really put people at the center of it all. A leadership that actually does the right thing for the people. And so our call to action, or the call to action that I present, is we would like to see a political courage to streamline basic progressive taxation systems, political courage to stop illicit financial flows out of Africa, political courage that actually deals with international tax evasion in our continent, political courage to stop greedy pharmaceuticals that put profits before lives, political courage to deal and fix absorption capacity bottlenecks in our region, political courage to stop human rights violations, eliminate gender inequalities and other social barriers to equitable access to health services, political courage to invest in prevention research, innovation, and scale-up of proven tools and interventions, political courage to do the right thing for the people. I thank you very much.